Is that Priya? Hello?
Yes, Akansha, I can hear you.
Why do you call yourself iPhone? Why don't you write yourself Priya?
Yeah, I always do that after I come in. I was more excited to say hello to you before I did that.
Yeah. How are you?
I'm okay.
Cool.
Yeah.
I'm doing all right. Today is the last day of my job in here, and then I'll be moving over there. So, anyways, we'll talk about that later.
Sure.
Yeah.
Hi, Akanksha.
Hi, Raji. How are you?
Good. Thank you. How are you?
I'm doing all right.
I'm not able to share my screen.
Yeah, just give me a second. I'll make you co-host. Okay, now you should be able to.
Let's just give 1 more minute and then start.
Yeah, let's get 1 more minute. Shweta is yet to join. I wonder if she's. But otherwise, we have Halima, we have Priya. We have Dr. Iqbal.
Hey, Akanksha. I'm Rajeshwari. How are you?
Very good. How are you?
Good.
Hi, Dr. Iqbal.
Hi, how are you?
Good. How are you?
I just came. Hey, how are you? We'll talk. Okay.
Okay. I think we could get started.
Yeah, I guess.
Okay. So have people seen cases today?
I've seen some cases, not all of them.
Okay.
Yeah, I too saw cases.
Okay. I mean, T cells they're not that interesting like B cells. So there might be I have different disorders, but by flow, it might all look like the same.
I agree.
Yeah. Okay. So first one, is someone gonna try this?
I can try it.
Okay.
Okay. So with this one, so the first tube, CD45 and side scatter, I'm looking at, we have a purple population and we have green and red, and then there's an orange. So coming to CD19 and side scatter, I see that we have the green, we have B cell population, which are green and red. And then there is a purple population, which is CD19 negative. So, and then we have an orange population that's CD19 negative as well. So looking at this tube, I'm thinking that the orange population is my T cell, which is CD5 positive. And then my purple population is also T cell, which is CD5 positive. And my red and green population are B cells, which are CD19 positive. And the B cells are kappa lambda, like proper ratio. And then they are 10 negative and 5 negative. So I'm interested now with my purple population and orange. So looking at the purple, it's 5 positive, 38. I can't really see. So 10 negative, 200 positive, 3 positive, and 5 positive, like we said. And then the orange population were 5 positive, 200 negative, 10 negative, 38 pos, and 3 pos. So I'm more interested. Okay, let's go down to the second tube. So here, the second tube is, I'm seeing again the same thing, blue population, which looks like my T cell, and this 45 side scatter is very similar to the population for tube 1. Then also my red population, which is 7 pos, looks like my T cells, and then where is my I'm trying to find where my B cells are. Maybe they're masked in the background. So the purple population looks like my 2 population because there are 7. It's 7 negative, 2 pos, the CD3 positive, 5616 negative, 4 positive, 5 positive, like we said, 3 positive, 10 negative. So my blue population is of interest because it's 7 negative. And then the red population, it's exhibiting all like pan T cell antigen. So I'm thinking it's nothing abnormal about it so far. There are the red is 4 pos, and I think and there has to be like there are 8 pos. Okay, so blue population is the one that looks abnormal because it's 4 pos, and 7 neg, 5 pos, and 3 pos. And okay, so we can go to the third tube. Or was
that's it.
Oh, there
That's
was
it.
no third tube. Okay, so I think because the 7 negative, I was thinking, and 4 positive, looking at the table, I was thinking that it's a 4 positive lymphoma. I was thinking of ATLL.
Okay.
Yeah, because it's 8 neg, 7 neg, and the 3 was negative, and it was a little bit dimmer than my background normal T cell population, and I would want to see then CD25.
Okay. That's fair. I mean, for this one, we would just call it CD4 positive T cell lymphoma or CD4 positive aberrant T cell population. And I mean, most likely with T cells, we will not call anything else other than aberrant T cell population. And we will say whether it is 4 positive or 8 positive at the top line, except for, I mean, LGLs and NK cells are mycosis fungoides or cesarii. I'll come to that when we come there, but for all other things, we will just say aberrant CD4 positive or 8 positive T cell population identified, and we will leave it there. We won't go into the diagnosis. Like you said, we can do, this is a lymph node. We can do CD25 for ATLL, but I think we had enough from this because this was a peripheral T cell lymphoma, and we had enough, so we did not go there.
Okay.
Yeah, but I think what you described is right. So we have our CD45 bright population here, which are lymphocytes, and some of them have high side scatter. PTCL can have larger cells, and the red and green are the B cells, like they are CD19 positive, nice kappa lambda ratio, and you have your T cells that are positive for CD5. A subset is positive for CD200, and that subset also has a dimmer CD3 compared to the background bright CD3 positive T cells. And here, the green population are the CD8 positive cells, and the red population are the CD7 positive cells. And the dark blue is the one that is abnormal, that has 2 but has completely lost CD7, and it is negative for 15, 60, 56, and 16, and it also has dimmer CD3 compared to the normal cells. I mean, it does have variable CD3 expression in this one, mostly dimmer.
Hey,
So
Raji.
yeah.
I have seen in almost all of the cases that on this CD4 and CD8, there is kind of this, there is that red population trickling up, which is kind of 4 and 8. Is this like we should just call it normal like this, or like how would you explain this?
In this, but I mean, I have to see. I don't really have an explanation for this one. but it's just gated that way. If I see another one, we can talk. If you see something similar in another one, we can talk about this. But this one I don't really have an explanation.
Okay, got it.
Yeah.
Did you say this is a peripheral blood?
Oh no, this is a lymph node.
Okay.
This was peripheral T-cell lymphoma,
Okay.
CTCL in a lymph node.
Shouldn't we supposed to see like a downregulation of 5 in PTCL?
Sorry, what? See what? I didn't.
Downregulation of CD5?
It can, it cannot be.
Okay.
So here's the thing, in T cells, there are certain entities that have some specific phenotypic abnormalities, but they all have variable phenotypic expression. I mean, some cases can have 5, some cases can lose 5. That is not reliable. And even with 7, some PTCLs still can have 7 expression. As long as you see a population with a different intensity of CD3 or a different intensity of any of these markers from the background T cells, and you see some aberrancy in them, it is aberrant. It's very hard to put down on which is the only marker that would be lost, except for if you say mycosis fungoides, 7 would be lost. Sézary syndrome, 7 would be lost. But for anything else, it is very hard to say what will be retained and what will be lost. Something would be lost, and it is more often 7 and sometimes accompanied by 5.
5, yeah. Okay.
Yeah, but it is very hard to say.
So what is this light pink population, which is double negative for 4 and 8?
Yes, so it is double negative for 4 and 8. Can you guess what it would be?
It's also negative for CD5
It's NK
and
and
CD3. So are they usually there in the lymph node, the NK cells?
You can have some circulating peripheral blood cells when you do your lymph node flow. Actually, this one even has granulocytes. So that is possible. Actually, there was one time when I was a fellow.
When I looked at it, I actually thought it's a peripheral blood.
Yeah. This one has lot of contamination, but majority of the cells are actually lymphocyte. This was actually from a lymph node. So one interesting experience was there was nasopharyngeal mass in a patient, and we did flow on the nasopharyngeal mass, and it had these nice 56 positive cells that are 8 positive. And then we thought it's a nasopharyngeal mass. The specimen had a lot of necrosis, so we thought it's NKT cell lymphoma just by flow. We didn't call it that, but we reported that population. And then when we caught the specimen, we looked for the NKT cells. We didn't see that. And then they rebiopsied. We again did not see that abnormal T cell population. We only saw plasma cells. So then he kept on having his CBC, but a smear was never made because his CBC was normal. Then at one point he had a smear made, and then we saw an increase in the NK cells or the granular lymphocytes. So then we figured out those were just circulating NK cells that we picked up in the flow, because there was a lot of necrosis and granulation tissue. So it was actually, he just had inflammation and never had any lymphoma.
There's something similar over here. And on 56 and 16, how do you read that? 56
Sorry?
and 16.
Yeah, here, this is positive.
56 and 16 on the dark blue population.
That is negative.
It's negative.
Yeah. I mean, we have the NK cells that are positive here.
That's correct.
Yeah.
So the only aberrancy that you see here in those T cells are absence of CD7.
CD7 and a subset with dimmer CD3. That's the only aberrancy in this one.
But isn't that seen? I mean, CD7 can be lost even in reactive conditions.
Oh, not to this extent.
Okay.
Yeah,
So,
I mean, you will see like a very, very small subset losing CD7. Sometimes in specimens you can see, but you will see more 7 positive T cells than the negative ones. This one is like overwhelmingly large population.
Okay, and it's a homogeneous dot. Okay, all of them staying together. Okay.
Right.
I just had a question. Is this Is this normal? 56 and 16 are they on the same fluorochrome?
Yes, they're on the same fluorochrome.
Is that normal? Because wouldn't there be an entity where we something would be 16 positive and 56 negative, and it
You
would
can have entities, but the purpose here was to just isolate the NK cells. And in our leukemia tubes, we had 56 and 16 separate.
Yeah, okay.
But in the T cell tube, we had it together. And we also have 13 and 33 together in our BALL tube. So it can be done.
Okay, but what
Yeah.
was the purpose? Because 16 itself will be able to isolate them, right?
Sorry?
No, I was just wondering what the purpose was, because 16 itself would be able to isolate them.
16 alone?
Yeah.
No. So NK cells does have a spectrum. There will be some that are 16 positive, there will be some that are 56 positive. If I'm not wrong, the maturation is like it is usually 56 positive in the beginning, and then it becomes 16 and 56 positive, then it becomes more 16 positive.
So, okay, that's actually, I find that's smart actually, because I don't think I've seen that. And
yeah, so we see a population of NK cells that are just 16 or just 56 in our in our separate tubes sometime. So we combine it in this one.
Okay, got it. Okay.
Yeah. Any other questions? Okay, let's go to case 2. Case 2 is actually peripheral blood. I mean, it's hard to believe from the 45 versus side scatter, but this was peripheral blood.
Okay.
Does anyone want to take it?
Yeah.
I mean,
Looks
if nobody takes, I will take the cases. I have seen them all, but I'm giving like others, like whosoever wants to take the case can take.
I mean, it's usually the two of you or sometimes Priya.
Yeah, so
Okay, I'll take the second one too. I
Okay.
I saw it, but I have no idea what it was. I mean, it was vague still for me. Okay, so CD45 site scatter. We have majority of the events are lymphocytes. So the blue population is, so I'm interested on, okay, so 5 and 19 plot, I can see that I can see two populations. There is 5 negative, and then there is 5 positive. So looking at the 5 positive, because it's majority of our events, it's 5 positive, 20 negative, 23 negative, and 19 negative. So let's look at the second two. So is this the same population that we were talking before? It's looks like that's my green population, and it's 3 positive, 7 positive, 4 positive, 8 negative, 2 positive, and 34 negative. So it's a mature T cell, and this one didn't have any, there's no pan-T-cell antigen loss. And the only thing is there's no 8. I'm thinking 4-to-8 ratio would be high. So
Right.
that's the only thing. So I would call it like a 4, but there is no loss for any T-cell antigen except 2 is a little bit dim.
Yeah, so there's really no loss for anything.
Yeah.
So that is another thing, that if you don't see any loss, still there is not having 8 is an aberrancy. 4 and 8 are just like your kappa and lambda of the B cells.
Yeah.
So when you see just 4, you can say that it is restricted, kind of. It is like restricted. So you can say that
positive T-cell neoplasm.
yes, CD4 positive T-cell lymphoma. That's what you will say.
Okay.
Right. I agree there is no aberrant expression, but because having just 4 is not normal either.
Yeah, and I think on CD2 and CD7 plot, the background, that like tiny purple background cells are my normal T cells. So I could use it for control, because my aberrant population it has a slightest dimmer CD2 expression, right?
I'm not sure if those are normal controls. I mean, that's
Or
gated,
could be
it's
the
there, but it does not have a it does not have a surface CD3.
Okay.
I mean, it has 4, it has 7. I'm not sure if it is any if it is anything significant actually,
Okay.
because it does not have 3.
Okay. And what was the reason for the gate 1? Why was there a gate drawn on that population?
So that one had really bright CD3 and 7. And even in this one, you could see like that population looks like it is so bright,
Okay.
but it didn't have anything different from the other T cells. It was still just 4.
Okay.
So we just gated it to see if it is behaving any different, but no, it was just the same.
Okay. Got it.
Yeah.
Right. So it's 4 positive T cell lymphoma.
Right. Agreed. Any questions? This one was actually pro-lymphocytic leukemia.
Nice.
Yeah.
Did you eventually do the CD52 and TCL one?
No, we don't have it. We have IHC for CD52. We do it always because of alemtuzumab. That's an antibody.
Yeah.
I mean, they have targeted therapy for 52, so we do that.
Okay.
But this one was confirmed by FISH, basically.
Yeah. Eventually, yeah, it requires a fish too.
Right.
Yep.
Yeah. Okay. This one. I have to recollect what. Okay, this is peripheral blood actually. We had some circulating cells. Patient had lymphadenopathy, and then this is peripheral blood.
Okay. I can look at it and then I'll leave from here.
Okay.
So CD45 forces site scatter. I can see that the gate of the lymphocytes, there is 2 population there. So the green population has a little bit higher site scatter. And then I can, and then there is like my red and green, which just looking at this tube and looking at the CD19 versus 5 plot, I'm assuming that those are B cells, my red and green. And then I have an orange population, which is 5 positive, 10 positive, 19 negative, 38 dim, 200 dim, and I'm thinking those are my T cells. And then the green population, which was CD45 bright, is 5 negative, 19 negative. It's looking as if it's kappa lambda there, but I'm thinking it's like, because the fluorochrome is sticky, the one that we put on kappa and lambda, that they're just sticking there, but I'm not sure. I'm just
right. It is just sticky. It's not positive.
Yeah. Okay. Good. So my green population is 38 positive, 10 negative, 200 negative. So looking at, so this is the first tube. Looking at the second tube.
So what do you think is the green population?
I'm thinking if they're T cell because they're 5. Oh, I don't know that yet. It's 5 negative. So it's some sort of CD45 bright population.
What actually sits there in 45 versus site scatter? I mean, these are your
monocytes sit there. Monocytes sit there.
Yeah. So they are your monocytes.
They are my monocytes. Oh, okay.
Yeah.
Ah,
Okay, that's okay.
Sorry
It's
about
just
that.
gated at different
Yeah,
strains.
they're kind of weird. I know.
Yeah. I think they have included some degenerating grants and grants in there, but those are actually monocytes.
Okay. All right. So now this tube, I have my, so it looks like I have on my plots, kind of a 3 population. There's a red population that is 4 positive, 7 positive, 5 positive, 3 positive. There's a green population, which is also expressing all T cell antigen, 7 positive, 5 positive, and 3 positive. And then there is a blue population that is 7 negative, 2 positive, 5616 negative, 3 positive, and 5 positive. So I think the blue population is the abnormal one. There's a loss for 7, and it's 10 negative. So this was case 3. So, and then there are 4 positive. So 7 negative is the only abnormality, and I don't have enough information except saying, I guess, 4 positive T-cell lymphoma.
Okay, so this
But
10,
there's 10. Oh, theirs was 10.
Yeah, there is some 10.
There's a partial 10.
yeah, so there is a partial 10, and you can have you can see your background lymphocytes here, the red population, that doesn't have 10. The blue has like this smearing pattern. And this is the best it gets, actually. I have never seen a clearly homogeneous 10 positive angioimmunoblastic T-cell lymphoma. The ones that I have seen have always been like this, like partial.
So
This is the maximum it gets, and the normal T cells are like nicely negative. There is not even like a spray or anything. It's usually nicely negative.
okay.
So when you see
You mean
even
the mature T cells?
normal mature T cells, yes.
Yeah.
It's quite dim. Yeah. Okay.
Yeah, it is dim and it's partial, but that's how much you will see in
Okay.
AITLs. I have never seen anything brighter. This is the brightest I've seen, actually. Yeah, so this was an angioimmunoblastic T-cell lymphoma, or you can also say follicular nodal follicular T helper cell lymphoma, but these were circulating cells. So we say that aberrant T cell population with CD10 expression, and then in the comment we say, these are the differential diagnoses correlate with morphology of the lymph node for that.
Okay.
So, but pretty much negative for 7, and expression of CD10. Actually, 3 is a little bit dim, but it's very hard to say.
Yeah.
Yeah. Okay.
Awesome. Thank you.
No problem. Any other questions?
In the previous case, what is the significance of CD200 in T cells?
No, nothing. Actually, it is in our B cell tube.
Oh, okay.
So it is always there. As such, there is no significance.
So 200 in T, no significance. Okay.
I have seen 200 positivity in all kinds of blasts and in some T cell. Maybe it's worth looking at which T cells are positive for 200. I don't know. But we have seen 200 variably positive in different T cell lymphomas, but I don't know of any significance that it carries.
Oh. Can you pull up the CD4 versus CD8 on that case? Sorry, it was just in my notes that I had to see that plot.
This is the 4 versus 8.
Okay. Yeah. So this is separate, but then the 8 has kind of negative is NK cell, and then the stronger ones are the CD8 positive cells.
Right. This is the dimmer, the purple one are the NK cells. NK cells do have that variable dim to positive.
Okay.
Yeah, that's how they usually are. So that's okay.
Okay.
Okay. Next one.
Hey, this is Priya. I can try this one.
Yeah, go ahead, Priya.
Okay, so in the Cytometry CD45, we see a 73% lymphocyte population. The lymphocyte population is CD5 positive, CD19 negative, CD23 and CD19 negative, FMC 7 negative, 200 negative, CD5 positive without light chain expression. So this is just a a non-B cell population.
Right.
Here we see again gated as green. The lymphocytes are CD3 positive, CD7 negative, CD5 positive, CD3 positive, CD2 positive, CD4 positive, but CD8 negative. So again, we see, CD8 negative, CD3 positive, CD4 positive. So basically we see a T cell population, CD4 positive T cell population with loss of CD7. And so CD56 versus CD 16. So CD16 is negative, and I would say CD56 is also negative.
Right.
Yeah. So then here, again, we're getting the same population looking at CD117 positivity. It's negative. So CD117 negative, CD2 positive, and CD25 positive or DIM positive, and CD117 negative. So I think this is a CD4 positive abnormal T cell population expressing with a loss of CD7 and partial DIM positive CD25. So I would say differential would be human T cell leukemia lymphoma or peripheral T cell lymphoma not otherwise specified.
Okay. So yeah, this one was actually a peripheral blood, and it had a lot of those flower shaped cells or clover leaf shaped cells. And like you said, it is correct. This is all CD4 positive T cells with loss of CD7 and partial CD25 expression. And I called it suggestive of ATLL, adult T cell leukemia lymphoma. One nice thing about this one is you actually see how dim the CD3 is compared to the background normal T cells here. And those are actually 8 positive cells. And it's seen here also. The background T cells are kind of brighter CD3, and this one has a dim CD3 compared to the background. So, I mean, even here you can see, like you have your polyclonal T cells are here, and the CD3 is dimmer than that in this one. That's one nice thing to see.
Yep, that's nice. Yep.
But otherwise, this is just same thing, except that CD25 is partial, and it was an ATLL, this one. All right. Okay, this one.
I can't see.
Rita, it's yours.
Okay. So in this one, we see a lymphoid population on site scatter CD45, which is 28%. And it is 5 positive, and then B cell markers are negative, 19, 23 negative, FMC7 negative, 200 negative, 23 negative, and then kappa lambda negative. So far it's 5 positive, which is in place there. Then it is CD3 positive, 5 positive, then it's again 2 positive, and then in CD4 to CD8 ratio is markedly increased, like it's CD4 restricted population, so which is like the first point that is important here. And then again it's CD4 positive. I do not see any loss or dimmer expression of any of the antigens so far. And then again yeah, so and then there is loss of CD7. So again, we will be just saying it as a CD4 positive T cell, aberrant T cell population with CD4 restricted population and aberrant loss of CD7.
Right, yeah, so we'll just say aberrant CD4 positive T cells. So this one was Sézary syndrome, but again, it looks the same. But I have nothing to add other than what Shweta described. Pretty much the same. That's what I said, like I have different disorders, but they all look the same. So maybe this one will have something additional for.
Yeah, this is a good one.
Yeah, okay.
Yeah, this I remember from my fellowships, like we used to do
Nice.
this.
Okay, okay,
Yeah.
yeah.
So it has that classic like 26, right? Is it that
Right, right. This one has 26.
Yeah. So 26 one, yeah. This is the one you do for CTCLs. So here this black population is the one which is abnormal, which is on CD45. It is slightly higher on CD45. There is no increased site scatter, but little bit brighter on 45, I would say that. And then it is hiding in the CD4 to CD8 plot somewhere. And then on this plot, it is CD2 positive.
Oh, Shweta, Now okay, so sometimes you will see cells in the CD4 and 8 positive area. And we had a nice histogram for forward scatter. These are doublets.
So we see them all in all this. I mean, I know like thymus could have it, but like, do we see it like on normal like lymph node?
No, you don't. You don't. So those are doublets. So those are 4 and 8 positive cells that are sticking together.
Oh, sticking together. Okay.
Yeah, those are doublets. So it is actually painted in a way that those are kind of either 4 positive or 8 positive, but it's neither of them. Those are actually 4 and 8 double positive cells sticking together. And they will have higher, they would, if you kind of gate that and backgate it, you will see them in the high forward scatter area.
Oh, okay.
So most normal cases will have some of them. So it's okay if you have just some of them, and if they are sitting in the high forward scatter area, just ignore them. Otherwise, you have to work it up. Yeah.
Okay.
Yeah, just my brain froze when you asked that question. Those were doublets. Okay. Yeah.
Okay. So
Sorry, can you please clarify, Rajshri, again, where is the doublet population in this CD4, CD8 plot?
So there you will sometimes see
That
cells
one,
here
okay.
that are double positive for 4 and 8. So sometimes it may not be really double positive. They are just doublets. Doublets means like in flow cytometry, ideally you should only see one cell passing through that chamber at a time.
Yeah.
But sometimes you have 2 cells sticking together going through that. And we eliminate that with our FSA versus SSA plot. We just choose that diagonal population and eliminate the population with high area. But even then, there might be some cells that we miss. And these cells typically have high forward scatter, so
okay,
we can just eliminate them. Yeah.
Yeah. So on this one, now I remember, it's like on 4 and 8, this blue population is abnormal, and then this blue population also further splits. I would say like then subset is 2 positive and subset loses 7. All of it loses. Sorry, 2. I'm talking about 2. Some has 2, some loses 2, and 7 is completely lost in all of it. 56 and 16 is negative. Then it is 3 positive again. It is 56 and 16 negative. 4 is positive in this population, and then 7 is negative, and then again 7 negative, and it is 5 positive with little bit spectrum on it, I would say, and then it's 3 positive, and then yeah, it's again and it is 10 negative. And if we go down, so this is this is yeah, it is 4 positive population. Then as I said, like it is 4 positive, subset has 7 loss on it, and then 26 is something that we look for, like in the 4 positive cells, if there is a loss of 26, so those are the percentage of the cells that we have to see to see if it is a CTCL, like Cesare or MF, those kind of, this is the plot that you go after for like diagnosis and then like monitor the disease. So 26 loss, that's what we look for. Yeah, and the rest is kind of the same, I guess.
Right. Yeah. So you're right. So the black population is our population of interest. The blue, we are not sure whether it is neoplastic or not. In fact, the blue has the same intensity of CD3 and 5 like the red or the background normal cells, whereas the black has brighter 5 and dimmer 3 than the blue. So it could be just normal background T cells. So this is a peripheral
just like
blood.
we had 7 loss. So I was thinking, is it like subpopulation of like, you know, the lymphoma itself, like kind of split, like some has it, some lose it?
So it can happen. Normal peripheral blood will have some CD4 positive cells that lose CD7. So that is normal. You can see a little bit, especially like this amount is normal. But they will not have difference in intensity in expression of any other markers. So we would favor that this is just normal background CD4 positive T cells with loss of CD7, because this one clearly has dimmer CD2, brighter CD5, and dimmer CD3. So this one we are sure that this is neoplastic, but this one we would favor normal, but again, there is no way of telling. that this is just normal, but that's what we would favor. And you said, like you said, this is the most important plot for mycosis fungoides of Sézary syndrome, because loss of CD26 is what defines those cells, and we use that for staging. Having more than 1,000 cells per microliter and all that is involved in your staging. So the clinicians are always looking at the number of CD4 positive cells that have. So we give different numbers: 4 positive CD26 negative, 7 positive CD26 negative, and then under the 4 positive cells, we also give 7 and 26 double negative. We give all these numbers, and they use this for follow-up if it is increasing or decreasing with treatment, and they use it for staging also. So this number is always important. 4 positive cells that have negative 26, that number goes into the report. And also they say that 7 loss can be variable. You can have some cells that have variable loss of 7 and some cells that have complete loss of 7. So yeah, that's pretty much in this plot. And in this also you see that the 7 and 26 negative cells actually have the dimmer CD3. So yeah, any question?
So what is those cells which are negative for CD3? No, they have dimmer CD3 and 7 and 26 negative. Okay, got it. Sorry.
Yeah, neoplastic cells.
I'm
Those
fine.
are yeah. Okay.
Yeah.
Yeah. Any questions?
No, so see, just the one. So the the reporting diagnosis was Sézary, or was it?
No, we'll just say aberrant.
Just aberrant
CD4 positive T cells identified, and we'll give the number.
Okay.
Yeah. Percentage of 4 positive cells that have lost CD26.
Okay, got it.
Yeah.
I have one question.
Yeah.
Not to this case in general, like CD26, where we have been reading other markers in the maturation. Where does CD26 comes in the maturation of T cells?
I don't know. I have to read about that. I just know that neoplastic cells of mycosis fungoides and Sézary lose CD26, but I don't know where it comes, which stage it comes, because I have never really done it in any other scenarios other than evaluating for CTCL.
Is it like in general in your panel to do CD26 or like?
No, we don't use it in the general panel. If there is a known case of CTCL, for follow-ups, they will ask specifically for Sézary panel, and this is an add-on tube for that.
Okay, got it.
Yeah, and normal T cells have 26, that I know, but I don't know when it is acquired.
Okay, all right, thank you.
Thank you. Any other questions? Okay. Okay.
Okay.
So anyone going for this?
I can take this if nobody is.
Yeah, go ahead.
Okay. On this one, I was at LGL. Okay. So in this one, there is I'm going after the green population here. So in this one, there is that green population, which is CD5 positive, slightly higher side scatter, which is which like LGL, they have granules, they can have that. Then it is CD8 positive clearly. See, I was telling you there was like all the plots have it, but now I get your doublets point there. Yeah. So yeah, so it is CD8 positive. It has a slightly dimmer 2, and CD7 is also kind of a spectrum here. Variable expression, I would say it is 56 and 16 negative, CD3 positive, CD7. There is like I would say a partial loss here, and then there is CD7 partial loss, and CD5 also is there a partial loss. It's kind of a spectrum there too for it. So I mean that is abnormal, and then it is so those are again the replication, kind of the same thing that is going on there. Then on this one is I forgot which color I had to follow. It's like I write in my notes.
Just use this one to say which one you want to follow. Just
Okay.
use the 3 versus 5.
So 3 versus 5. So there is a population of like this orange population has both 3 and 5 expression, and then this green population is our abnormal population, which has some 5 loss. Then this green population is 57 positive, and it's 57 positive. There is some 5 there is 5 loss on it, and then going down. I do not know 11C. Why we do it, but it has 11C, so I didn't know the reason for that 11C. Then is it like we are differentiating from more? I do not know what exactly we do 11C here for. Okay, and then it is again, it is this population is CD8 positive. And that is the fluorescent green population, and then that population is 28 and 27 positive. I am not used to these markers, but I was looking it up. These are like markers of T cells. So like resting T cells probably. So these cells are expressing it. So I do not know exactly the significance. I'm not used to using it. But like just looking at the other plots, this like there is a population, to me it looks like an LGL leukemia. It is like it was CD8 positive abnormal T cell population with some dim CD2 expression, CD7 down regulation, CD5 negative population. Yeah, so I would like raise a differential for, but LGL you can't make that diagnosis upright. Like you have to see how much count and duration and all those things. It could just be like LGLs are increased in the blood. So I mean, just like the aberrant population is LGL to me.
Yeah, okay. Yes, you're right. That is what this is. So for LGLs, like you said, the side scatter is high. They have bright CD45. The plot to actually look at is where you have your CD45 in the x-axis. You will see nicely a population of dim CD45. And if you're lucky, you will also see something that has lost CD45. Often you will just see a population that has dim CD45, dim CD5. And that's the population that you have to go after. So normal LGL markers you won't see in your regular screening tube. You have to decide when you want to add the tube. So this is when you add the tube. When you see a CD8 positive population that is positive for surface CD3 and has this dim or loss of CD5, that's when you add your LGL tube. And sometimes these cells actually appear to have brighter CD3 than your regular CD3 positive T cells, but that's not always the case. And so we see that not all our 8 positive cells are LGLs, because we actually see some here too. Like there are background cells here that are hiding behind the red population, both here and in here. But other than the 5, there is a little bit of loss of 7 and 5, there is no other marker that would be kind of different in this one. And so we get this population and we look for CD57 and 11C expression in this. So LGLs would be negative for CD56 and would be positive for CD57 and 11C. So that's what we are seeing here. 11C is positive in these LGLs and they're 57 positive. And again, in this one, loss of 27 and 28, that is abnormal. They should be usually positive for 27 and 28. Having loss of 27 and 28 is the abnormality here. So this is where those abnormal cells are sitting. And they have nice CD8 and CD3, but these are the normal T cells that are 27 and 28 positive. LGLs are 27 and 28 negative. So then you report it as this much percentage of large granular lymphocytes seen, and then you write a comment correlate with morphology and clinical presentation to rule out LGL leukemia. Never call it LGL leukemia on flow or even in your bone marrow. Never do that, because you can have LGLs increased even in normal conditions like post-transplant myeloma patients or patients on immunosuppressants for anything else, rheumatological disorders, autoimmune, all kind of conditions can have increased LGL, sometimes even more than 6 months. And once they take out the medication, the LGL just go down. So even if it looks like it is satisfying the criteria, do not call it. Ask them to correlate clinically. Yeah.
Hey Raji, which plot do you use for the percentage? Like to which, when you say this much percentage of LGLs are there, which plot would you use for that?
So we would take all the CD5 negative cells. We would use only this tube for that, for getting any percentage, because any add-on tubes can have some distortion of data. So we'll use our main T tube to get that, and all the CD5 negative cells is what we would take. DIM and negatives. This population is what we would take.
Okay, got it.
Yeah. Okay. Any other questions? Okay. Case 8.
This. Is it the last one? Is this the last one, right?
No.
I added one more this morning, so this is the last but one.
Okay, okay, 7. I can take it. I haven't seen it, but okay. Is everybody okay? I can take it.
Yeah, sure.
So CD45 site scatter. So those lymphocytes, and then the blue population is 19 negative. There is a partial 5 expression, 23 negative, 19 negative, 200 negative, FMC negative. So these look like my T cell. So the first thing that the only thing here on this tube shows that there's a partial 5 loss. Then
Okay.
going down. So here I have the there's one population that's 3 positive, 5 positive, 7 positive, 2 positive, and then it has like their ratio of 8:4, and then there's a blue population which is 5 negative, 7 dim, 2 dim, 4 and 8 negative. So that's looks like my abnormal T cell. And they're 3 negative, which is interesting. And then my 3 negative population is 57 positive, 56 negative, 5 negative, and it's 16 positive. And then there is a 3 positive, that's 57 positive as well. And 5 positive. So I feel like I'm dealing with 2 population. There is the abnormal population is the blue one, which is 3 negative, 57 positive, 16 positive. And I think those are the phenotype for LGL, right? That's what I'm thinking.
Yeah. Anybody wants to add anything?
I think we should think of NK too, like don't commit. It could be NKT cell, could something on those lines, because 16 positive, and then it is that is something is more in the NK cells, and then 57 is more of the LGL type. So I was thinking it could be NKT cells, or don't commit like here on any lineage, but it could be either of those, NK or T.
Okay.
I just read somewhere that I think it was differentiating between the LGL and NK somewhere, and it said the way you would differentiate between them is through the 57. 57 NK would not be positive. 57. I don't know. That's what I'm thinking. I'm not sure how good, if I'm remembering correctly.
But then that is 3 negative also. That population is 3 negative.
It is, yeah.
Okay. So the population of interest, so we all agree that the population of interest is this one, and the population of interest is negative for CD3 and CD5. It's negative for 4 and 8, and it is partial 7 and for 2 positive. So normally anything that is negative for 3 is positive for 7 and 2 and 16, we would think it is NK cells. So that's what we were leaning towards in this one also, because it doesn't have any 8 like you see in LGLs. It doesn't have surface CD3 like in LGLs, and totally negative for 5. So that's what we were thinking. And then this one has bright CD57. It has 16, and it did not have any 56. So NKs often have 56, but this one was negative. And the other thing is, like, NK cells can have various combinations. They can have 16 and 56, 57 only, 56 only, or any combination. Among the three, they can have any combination. So we really don't know which ones will be positive. So that's okay. But just by this, we cannot really commit that these are NK cells. Although we favor an NK cell in this one, we cannot really commit. We can use TCR to see if there are T cell rearrangements, because NK cells should not have T cell gene rearrangements. LGLs will have. Because they don't have the T cell receptors in NK cells. So that would help. And then the KIR flows can help. I don't know, there are probably just 2-3 labs in the entire United States that does that. So KIRs are just like your kappa lambda or 4 and 8. That's an equivalent of that in the NK cells. So you'll have 158 A, B, and E. So it should normally have like a distribution of the cells in there. Some of them should be A positive, some of them B, some of them E. If it is either just one, or if it does not have expression of all three, then it would be like restricted population or clonal or neoplastic. So that's what will, KIR and T cell gene rearrangements are the ones that would nail it for us. But just by this, like Shweta said, we cannot commit. It's more like NK or LGL, although we would favor NK by the phenotype.
So how would you finalize the report? 4 negative, 8 negative T cell lymphoma, and then we put the differentials?
No, we'll top line it as aberrant T cell population C comment, and then we will describe it and add this in the differential diagnosis.
Okay.
I mean, majority of my T cell lymphomas, the top line is aberrant aberrant T cell population identified. Majority.
Okay.
Okay, this one.
I don't think I've seen this. Was that on the Google Drive as well?
Yeah, since this morning, but
Okay.
don't worry. I mean, it's the same. It's just pretty much the same. Just take a look at it now.
Okay, I can. I don't mind.
Yeah. Okay.
So we have lymphocytes that are 20 negative. They're not showing any kappa lambda. They're 19 negative. So and there are 5 positive. So I'm assuming these are my T cells. And then tube 2 shows that there are 3 positive, 7 positive, 8 positive, 2 positive. So that the only aberrant so far is that they're 4 negative, 8 positive. And there's 56 positive and 16 negative. And they're 3 positive. And then, so we said there were 8, 57 negative. Okay, so there are 8 positive T cell population, but I'm not sure about the 56. Like we've been just talking about it being positive in NK, but these are not at NK because there are 3 positive. So we would just say 8 positive T cell lymphoma, like an aberrantly expressed.
Yeah. So aberrant CD8 positive T cell population. That's what this was. This was a TPLL. This was an 8 positive TPLL. 56 expression was kind of strange, but that's what this was, confirmed by FISH. I mean, your hepatosplenic would look like this, but it can be, hepatosplenic can be 8 positive and 56 positive, but that would be negative for CD5. This one was positive for CD5.
Oh, yeah. Okay.
Yeah.
I know we don't do flow for those meatals, but those can have 56 and 8 positive too.
Right. Yeah, it can have.
Even those
would actually,
paniculitis T cell, which we don't do flow, I mean, usually. So those are the ones like which can be 56 too.
Probably
Right.
that's why clinico-pathologic correlation. And
Yeah.
couldn't put the whole picture together.
Yeah.
Yeah, flow by itself, yeah, it's only for the antigenicity.
Right. Okay, that's all I have for today.
Just one question. I mean, if in general, for a T cell, a predominant population which is only CD4 positive, I mean, all the other markers are normal. There is no other aberrant antigen, but there is a lot of CD4 positive or predominance of CD4 positive. Would you, I think in WashU, we tend to just say that T cell population with predominance of CD4. I mean, we don't necessarily call it a T cell lymphoma. What would you say about that?
We usually say aberrant CD4 positive T cell. Okay, you won't even call it aberrant because there was no aberrant. Yeah, some people do that.
Okay.
Maybe that's a safer way of doing it.
Yeah, I think we used to do it that way too. Like we never like if no marker is lost and only CD4 is increased, like we didn't call it, like, you know, because you can see those T cells can be like predominantly positive, as you said yesterday, like in NLPHL you can see, in I think Hodgkin also you can see such kind of populations, I think.
And yeah, we tell them to follow up closely. Yeah, something like that.
Okay, that's reasonable. I mean, if there is absolutely no CD8, then you can say it's suspicious for lymphoma.
Correct.
But if you still have, if it is just predominant, then we would not call it anything, just predominant. That's what.
But I mean, compared to kappa lambda ratio, the 4-8 ratio, when they're reactive, they can widen quite a bit.
Oh, no. We don't call anything lymphoma just by the 4-8 ratio. Like I said yesterday, you can have very high 4-8 ratio even in reactive conditions.
Correct.
But if you don't see any 8, or if you see a difference in intensity of expression of your 4 positive cells compared to the 8s or the other cells, then you would say it is aberrant. Like I had in one case here, I think it was mostly just 4.
Yeah, the first or second. Yes,
like this one, this is just 4, but you can say that the intensity of these 4 was, I mean, it didn't lose anything other than 7, but the intensity was less, right? You know, even if it is background, a little bit of background 8. So if you see something like this, even with 7, then you can call it aberrant, because this is dimmer 3, or sometimes you'll see dimmer 2 or 5 or brighter 5.
Yeah.
You can call it. But anyway, for T cells, flow is of limited utility, like ATLLs, mycosis fungoides caesarea, LGLs, NK. For anything else, I think morphology is your determining factor.
Yep. Yeah. Okay. Thanks a lot.
Great.
Right. Thank you. Thank you all.
Thank you.
Thank you, Rajeshri.
Thank you.
Thank you.
Oh, the cases for tomorrow are there in the drive. For day after tomorrow, I'll put it a little, Friday's cases, I'll put it a little later on Friday. I think it'll be there around noon on Friday. I won't be able to put Friday's cases tomorrow in the drive. Just a heads up.
Okay, thank you.
Awesome. Thank you so much. I learned so much today.
Thank you.
Thanks.
Thanks, Raji. Thanks a lot.
Thank you. No problem.
All right. See you tomorrow.
See you. Bye.
Guys.